What's that? Nick. You like Nick? I don't know about the music too. Yeah, you laugh. I don't know what I can do with it. Yeah, let's go Kelly. No, let's go Christina. Yeah. Bring the porta potty.
We saw everybody. We saw Nick. house, we saw Jane's house, we saw my house, we saw Evan's house, we saw Jimmy's house. We saw everything. We did weightless. We went, and it felt like it felt like a roller coaster. When you
Get on the bench.
sweet, man.
Get on the bench.
When you're flying, it's like a weightless. Just like, let's go, let's be off, and you're like up in the air. Weird, Jake, it was like this. The wind is off. The wind is like up in the air. And you're control the thing. It's like you're just walking around.
The ball was in front, then there was a switch, and I got a the weightless thing.
You four. I'm sorry, guys. Because, you know, first, second,
It's me and Justin. It's me and Justin and
no,
Jake.
we have to get. Brian and Justin and Jake. Oh, good landing, Gary.
Did he bounce?
No,
No.
it's a nice, smooth landing. Schumann, Dr. Goodnight is her husband, and he's a pilot as well, and he's agreed to take up some of the boys too, because see, it's getting very dark, and we don't really want to be flying around after dark. So he's got a little airplane like Dr. Greer had, and he's going to take them like around one time and home, back to landing.
Big bite shot, like knocked him all over the face. So bad. It looks good.
Okay, guys, walk behind the wing. You see the wings of an airplane? Walk out there before you let it off. Go. It's getting too dark to roll. Tell Dr. Goodnight it's the last load.
You're gonna do weightless? No, what's the point of it? You get down. Oh, yeah, we did. Why not the runner, please? Come on. You're the runner. No, you let me drive. I push the thing straight down. Straight down. He goes, you want to drive? I go, I go, she did. He goes, it's only 60 minutes. Oh, we couldn't like grab, no grab. You can sit on the bench. I was like, sure. Please don't do it. No, I want him to do it.
Sit on those benches, guys, if you want.
Somebody's busy?
Yeah. Yeah. You grab onto the top. You grab onto the top. Man, we grabbed onto the top.
Jumped up and
we jumped up
laying,
and we are laying
on the roof. Yeah. If you jump up with weightless,
Dude, when you guys turned, did you guys go like this? Your arms was like,
I know.
no, if you went like this, you couldn't go.
So did you guys go
Who has not gone?
Dude, we did so many tricks. It was
Who has
we did like 8 weightlifts.
Well, if everybody's had a chance.
I'm going.
Dan, did you get a
I think I should get to go. Robert, no. I told him no second ride. So if you go anywhere Sandy Friday, come back. No.
I'm in bed.
All right, guys. Bonnie's time.
Yeah, can I ride that car?
I'm good.
Down, and if you want to hold this in your hand, and I'll count down, and we can we'll be ready to go. Okay, 7, 6, 5, 4, 3, 2, 1. Take it.
Clinical pharmacists like William Garnett performed the critical half-life studies to assess acid suppression.
With something like the H2 antagonist, the dosing interval will differ between peptic ulcer disease and gastroesophageal reflux. In peptic ulcer disease, we're primarily concerned about suppressing nocturnal acid secretion. With GERD, we're really concerned about suppressing acid secretion for 24 hours. And in fact, most people with GERD will have symptoms during the day. frequently after they've eaten, an hour or so after eating, and we have to tie what we know about the kinetics in one population to what we know about the kinetics and the dynamics in another population.
How are you? Good to see you. I'm fine. Was that too uncomfortable for you?
No.
Good. Were you able to be active?
Yes, I was.
That was an important thing.
Yes.
Did you eat regularly?
I did.
Good. Chest pain?
Had some.
Had some? Was it the typical chest pain that had brought you in the emergency room before?
Physicians like Dr. Richter conduct tests with a device known as a pH probe to confirm pharmacologic findings and correlate them to actual disease.
You told me that some of your original chest pain had even gone up into your neck and into your left arm. Did any of the chest pain this time go in that direction?
While I was sleeping, it
While you were
went
sleeping.
into my left arm.
Here we have the pH tracing of the lady that I had just recently spoken with. This is a dual pH study. That is, one pH probe is placed just below the upper esophageal sphincter. This is shown here in green. The other pH probe is placed 5 centimeters above the lower esophageal sphincter, and that is shown in red.
The pH probe measures the number and intensity of incidence of acid reflux over a 24-hour period.
And this chest pain came on during a period of time when she was having a number of episodes of acid reflux, particularly in the distal esophagus.
While the 24-hour pH probe examination is the most accurate way of diagnosing GERD, it is an expensive test and not widely available. Among patients who have not responded to a course of H2 antagonists, the recommended course of action is endoscopy.
There are two ways to look at evidence of esophagitis. One is by what you see when you actually put the endoscope in the esophagus. Is it red, irritated? Are there erosions or ulcerations? Certainly, if there's erosions or ulcerations, that's unequivocal evidence of severe esophagitis. The presence of just redness in the esophagus is a more uncertain way of judging disease. In any case, I always take biopsies because biopsies will not only tell you whether the inflammation is severe or not, but how long-standing it's been. And I also want to make sure there's no suggestions of early changes leading to cancer.
Well, one of the problems we have with gastroesophageal reflux disease is the testing that we have available is somewhat expensive. Certainly endoscopy is expensive, but I think it's important in a person who has recurrent disease. 24-hour pH monitoring is a very useful tool. I use it more for people who have atypical presentations of reflux disease like chest pain or ENT problems or pulmonary problems, just because endoscopy very frequently is normal in these patients. But again, that test is not available for everybody. Could we develop a simple therapeutic trial that might allow us to key on which patients really have GERD? The group at Phoenix VA, Sanowski and colleagues, have actually suggested, and they're the only ones that have done it, so we need to look at it, but maybe giving somebody 80 milligrams of a proton pump, in this case omeprazole, for 2 to 3 days, they found was as accurate as endoscopy or dripping acid down in the esophagus, what we call the Bernstein test, or 24-hour pH monitoring. Interesting concept. A lot of drug, but in the end, much cheaper.
Unlike the H2 antagonists and prokinetic agents, the proton pump inhibitors are long-acting agents and promote acid suppression for 24 hours. They are also more powerful and need only be given once a day. Dr. Richter summarizes disease management options among patients who have failed a normal course of H2 antagonists or who present with severe illness. One alternative would be to combine an H2 blocker with a prokinetic drug.
It's a good idea because the H2 blockers turn off acid or decrease acid. Prokinetic drug strengthens the valve, improves the emptying of the stomach of acid. So they're working in two different ways, and that might be effective. What's the cost? It's certainly more inconvenient to the patient. They got to take 2 drugs, and the regimens may be different. One they may have to take 4 times a day, the other one twice a day. The other thing would be to increase the dose of the H2 blocker. Double the dose, divide it 4 times, triple the dose. That becomes fairly expensive.
I started out taking that twice a day, and then we moved the dosage up to 3 times a day. And there's some days I'll take it 4 times a day. Sometimes it helps, sometimes it doesn't.
With the 3 and 4 times a day dosing, do you find it hard to remember to take it? Or do you just, when you have symptoms, or?
Yeah.
When you have symptoms, you take it, but...
That's exactly right. And there's times when I just forget it completely until I get in so much pain, then I'll go ahead and take it. But, you know, when you're busy, you've got things to do, school, I'm a full-time student, plus working, you know, I don't think about it all the time.
Or the other thing, in my own personal bias, my own personal preference, is to switch then to a proton pump. In this case, omeprazole, 20 milligrams a day, is very easy to take. They take it once in the morning when they get up, and I think it's going to be much more cost-effective and certainly as effective therapeutically as either of the two alternatives.
My tendency is not to try and increase acid suppression by increasing the dose of H2 blockers because you rapidly get to a plateau. 800 milligrams of cimetidine, if you double that to 1600 milligrams of cimetidine, may give you 20% more acid suppression, but you really don't want to push it further. You also get concerned about possible drug interactions at the higher doses of H2 blockers. So usually I tend at that point to switch them to omeprazole and a single daily dose, which will give you 95% plus acid suppression at that dose.
But can this benefit be quantified by pharmacoeconomic studies?
An outcomes analysis is intended to reflect all of the factors that drive cost and that drive outcomes in a healthcare system. So you should consider not only drug therapy costs, but all of the other factors as well, certainly including diagnostics, the use of laboratory procedures, physician encounters with primary care physicians and with specialists. All of these ultimately reflect the total cost from the perspective of the healthcare organization.
Using these parameters, Dr. Siegel performed a retrospective analysis looking at the records of 266 patients with acid peptic disorders over a 6-month period who were treated either with a proton pump inhibitor or an H2 antagonist.
The key question that we focused on in terms of cost of therapy is whether or not patients who are treated on omeprazole have lower total cost compared to patients who are treated with histamine 2 receptor antagonists. As you see in this figure, patients who were treated with omeprazole had an average cost, considering drug therapy costs, diagnostics, and physician encounter costs, of approximately $400. This is compared to a figure of $600 for patients who are treated with histamine 2 receptor antagonist.
But I think it was a good study.
Yeah.
And I think we need to consider doing more.
Although this study was performed before the availability of generic cimetidine, a sensitivity analysis was performed showing that cimetidine would have had to be 75% lower in price to reach a break-even point. Several other outcome studies have demonstrated similar results. One of the better analyses was conducted by Dr. Alan Hillman and colleagues. Clinical pharmacist Dr. William Garnett.
Dr. Hillman and colleagues compared 3 treatment groups. The first group was phase 1 therapy, which involved lifestyle modifications plus antacids. The second group were patients who would have received phase 1 therapy plus 20 milligrams of omeprazole per day. And the third group were patients who would have received phase 1 therapy plus 150 milligrams of ranitidine twice a day. Hillman and colleagues analyzed the direct cost involved in treating these patients for a 7-month period. They found that for the phase 1 therapy alone, the cost incurred would have been $7,585. For the patients treated with phase 1 plus ranitidine, the total direct cost would have been $6,733, whereas the total direct cost for the patients treated with phase 1 therapy plus omeprazole would have been $4,880. If you look at the difference, the omeprazole is about $1,800 less than the ranitidine-treated patients, which is a difference of about 26%, and is about $2,700 less than the patients treated with phase 1 therapy alone, which is a difference of about 39%.
Dr. Joel Richter, who was part of the Hillman study, cautions that none of the outcomes analysis studies have been performed over a long period of time.
The problem I have with the outcome studies is that GERD is a relapsing disease and that a lot of people will need to be on therapy for a long period of time, and none of the outcome studies that I'm aware of have really addressed that. So if you look at the simple endpoints of relief of symptoms and healing of esophagitis, and the outcome studies then have compared generally an H2 blocker to a proton pump. Not surprisingly, because the powerfulness of the proton pumps, the proton pump drugs have been shown to result in more rapid relief of symptoms, generally within 2 to 4 weeks, and more rapid healing of esophagitis, generally in 4 to 8 weeks. On the other hand, the H2 blockers are good, but they may take 4 to 6 weeks to relieve the symptoms, and sometimes it's not even 100%, and the esophagitis will oftentimes take 8 to 12 weeks to heal.
And Dr. Richter said the ulcerative esophagitis may never heal if it is very severe. For some patients, surgery might be a more cost-effective outcome than medical treatment. As for the overall question of disease management, Dr. Richter reaches this conclusion.
Gastroesophageal reflux disease is a very common problem presenting to physicians. It's probably the most common upper GI complaint. It frequently presents with heartburn and regurgitation, but patients can have atypical presentations mimicking heart disease, mimicking ENT problems, and actually mimicking asthma. We have the tools today to diagnose these patients' problems, particularly the upper GI endoscope, and most importantly, in 1994 and 1995,